Okay, can you hear us online?
Yeah.
You can. Excellent. Thank you very much. Um, so welcome everybody this is the session that is titled Care is Research and Research is Care, strengthening collaboration between health authorities and academic institutions to advance shared priorities. So I want to start off by just acknowledging the lands that we are on. So these are the traditional, ancestral, and unceded lands of the Silk Nations. That's not a nation that I often refer to, but it's an absolute joy to be here in what is now Kelowna, and recognize that I typically work on the lands of the Coast Salish peoples. My name is Sterling Bryan. I'm the Chief Scientific Officer at Michael Smith Health Research BC and a prof at UBC. And I have to say, I'm really excited for this session. I think we've got a stellar panel, and it's going to be a fascinating conversation, in part because of where we are in healthcare currently in 2025. It was just wonderful to have Minister Osborne make some opening remarks this morning, and to hear the commitment to research driving improvement in the health system in British Columbia from her perspective, and for the focus to be on implementation of research to tackle the key important challenges we have in healthcare currently. I also want to make reference to the name Penny Ballem. Penny Ballem is Dr. Penny Ballem, of course, is now in the role of President and Chief Exec at the Provincial Health Services Authority, and is tasked with bringing reform to the health authorities. And I think that context is important for our conversation today. How do we ensure that research is leading to providing solutions to those who are tasked with running health systems as well as delivering care in the health system? So we have, as I say, a stellar panel. I'm not going to do long introductions for all of our panel, but I just want to say how excited I am for us to have Kathy Ulrich on the panel, who's the former president and CEO at Northern Health. We've got Kate Ketch, so I know Kate well, Director of the Department of Evaluation and Research Services at Fraser Health. We've got Christine Voss, who's here with us in Kelowna, who is an assistant prof in the Centre for Chronic Disease Prevention and Management in the Southern Medical Program and in the Department of Pediatrics at the Faculty of Medicine. And then Leah Lambert, who is the Executive Director and Senior Scientist at BC Cancer and a clinical assistant professor of nursing at UBC Vancouver. So what I have suggested is that we would have an opportunity for some storytelling time. So we're going to start off with some storytelling from each of our panelists. We'll then engage in hopefully some conversation, as well as an opportunity for some reflection from the audience. So please use Slido to provide comments and questions as we progress the conversation. And we will be done by 5 minutes after 3 o'clock Pacific time. So without further ado, I'm going to pass to Kathy Ulrich, if I can, to be our first storyteller. Please go ahead, Kathy.
Okay, well, thank you, Sterling. I'll just maybe do a sound check. Are you hearing me okay? Okay, I'll speak up. Okay. It's a pleasure for me to be with you today, and I'm calling in today from the traditional and unceded territory of the Lheidli First Nation in northern British Columbia, where I live. So this was a real opportunity for me to do some reflection on my time as CEO in Northern Health. I left that role in early in 2024. So my reflections are over that time that I was CEO, and particularly in relation to building a culture that fosters and engages with research. That's a journey that I know is still continuing today. When the health authorities were formed, there was limited research presence or capacity in northern British Columbia. And today we have a health research, interdisciplinary health research institute at UNBC. A Northern Center for Clinical Research has just been established, and Northern Health has a team that leads the organization in relation to research. And that's a credit to the team of Northern researchers and at Northern Health and at UNBC, and many of the other partners who have engaged with us. So, as I was reflecting on that time and that journey, I was reflecting on some of the things that we did together that maybe moved us to that culture that we were desiring to create. And the things I'm going to reflect here are not sequential, they happened often concurrently. The first was to sort of on an ongoing basis assess the culture. What was preventing a research orientation, and what were the opportunities? And developing then alongside that kind of a shared vision with Northern researchers, service providers, physicians, and leadership in the region. In the early days, we did a lot of work on assessing capacity and where the gaps were. In Northern Health, it was largely about research leadership. And at UNBC at the time, the signs that many of the researchers who were junior were lacking to enable them to engage meaningfully in research with the health authority. Then we, I think, tried to keep in our consciousness how research-oriented thinking and action for both academics and for health authority staff and physicians could be made easy. And there's still more work to do there, but some of the things that we were successful at doing was, first of all, seizing opportunities. So there's a lot of focus on being strategic and developing a strategy. I think it's also alongside that strategy about being opportunistic, understanding and being attuned to the context of what's going on and where the opportunities are. Secondly, was building relationships and really seeking to understand. And I learned a lot through this. And it's a listening exercise to really understand where researchers were coming from, what were their needs, what were the drivers for their research and their careers that created some points of intersection with the health authority. And again, opportunism comes in there. Establishing multi-level partnerships was another piece that we worked really hard on. So institution to institution relationships and partnerships formalized into MOUs, governance structures between the university and Northern Health. And that led to further partnerships with the PHSA, provincial research institutes, and seed funding that brought together researchers, health authority staff and physicians, researchers in the north, as well as researchers in other parts of the province. Then I think next was some of the education within the health authority to help people learn how to engage with research. It can be intimidating. How do we make that something that's fun, enjoyable, and easy to engage with? So the seed funding was part of that. Things like research days, brown bag lunches, real-time knowledge exchange, where researchers were bringing new knowledge directly to the service providers. And then I think as I was leaving the organization, things like how do we engage differently with the people we serve? How do First Nations voices be brought into the research endeavor within the in the north, and that work is still underway to create a culture that fosters research.
That's an inspiring set of reflections, I think, to kick us off. I guess my one question to you is, can we persuade you to come out of retirement and back into the health system, given that? But maybe we'll leave that question until later in the discussion if we can. Kate, I'm going to come to you next. I just want to give you a reflection. So someone mentioned to me as I was walking into the room, they said they love the phrase research as care and care as research. Did we create this phrase for this session? I think the research directors of the health authorities have some responsibility for that phrase and for the work that's been done, as well as patient partners. But yeah, I'll pass over to you, Kate, please.
Thanks so much, Sterling. And I think you've read my notes, because I'm going to say the words research is care a few times in the next few minutes. And part of me also just wants to say ditto to what Kathy just said. So let's just see how this all goes. So good afternoon, everybody. It is my sincere pleasure to be a part of this panel today. My name is Kate Ketch, lovingly known as K2. And first and foremost, I would like to recognize that I'm participating in this session today on the traditional, ancestral, and unceded shared territories of the Katsi, Kwantlen, Coquitlam, Samialmu, and Tsawwassen First Nations. I am a settler who is humbled every single day that I get to live, work, and play in such a beautiful place like BC. Now, wearing my professional hat, I come to you as the director of the Department of Evaluation and Research Services at Fraser Health. In that role, I attempt and try my darndest to make research a living and breathing thing within the largest regional health authority in BC, largest by population, not necessarily by geography. I know my counterparts in Island, Interior, and the North, thank you, Kathy, also known as the other regional health authorities, would certainly have their own individual thoughts and perspectives to add to this conversation, but I think we all share some common barriers and facilitators within the larger health system, and I think they trust me to give voice to our sort of as a collaborative partner. So Cole's notes, it's from the perspective of a regional health authority research administrator and leader that I join you today. So a little bit more about me and my reflections. So I've worked in both academia and health authority settings throughout my career. So I've been on both sides. When I made the decision to join in on the Health Authority Research Fund about 8 years ago, my motivation was the following. This is what I was thinking. I am going to get to support research that truly matters, and it's going to have a direct and immediate impact on people's lives, both patients and providers in the system at large. Yahoo! Easy peasy, or cheesy. Little did I know that I had my work cut out for me. But with that, I truly do believe research is care. Seriously, not all of you know me, but I have a fair amount of tattoos. And if I was to get a work-related one, I would probably get research as care as that tattoo. That's how passionate I am about this. When I reflect on my mission or the vision I have for research at Fraser Health, and what I mean when I say research is care and care is research, to me, it means that we are active enablers of better health, better healthcare. And we do this by supporting physicians and frontline staff and external researchers to conduct research that are important drivers of quality improvement and innovation in the system. It means we don't settle for the status quo, but instead are leading the development of new practices and solutions through generating knowledge and implementing that knowledge as a part of care that has a direct real-time impact on outcomes in the system. So aside from continually advocating, highlighting the value, and trying to shift the culture of research within the Health Authority, the reason why I was really excited to join this panel is because I think a huge part of achieving our vision is partnership. I think it's a critical ingredient to making research magic happen. And I think we have a lot of untapped potential in improving partnerships between academic institutions and the health authorities. So with that today, I hope to bring some insights around strategies that have proved effective and some hints and tips that I think will be important to our academics to know if they want to better collaborate with the health system. Thank you.
Great, thanks very much indeed, Kate. So we will move to Christine, who's with us in the room. One of the things that I should have mentioned, and delighted that Christine is a Michael Smith Health Research BC scholar and a clinician scientist working here in Interior. Over to you, Christine.
Thank you. Just to clarify, I'm not a clinician scientist, no, but we'll get more to that. So thank you for the invitation to be here today. It's an absolute pleasure. My story today is about a woman who took a day out of her maternity leave to be here. She cares that much about clinical health research, and that person is me. So I'm a PhD scientist. I'm an academic through and through. And my research focuses on kids' physical activity behaviors. And I wasn't always working in a clinical space. So during all my formal training, I worked with the general population back in the UK, then at UBC when I did my postdoc. And that was the time where I learned all about, how to design a robust research study, how to mitigate the biases we bring to our studies with the methods we choose, the opinions we bring, what tools to choose, all those kinds of things. And that was a fun time. But I really, truly became passionate about research when I took a position at BC Children's Hospital. I was embedded in the pediatric cardiology clinic, and we were building a research program that was looking at physical activity in kids with heart disease. And that was really when I felt like for the first time I was putting my skills as a scientist to really good use. That was a population that benefits even more from physical activity than the general population, but it's a very complex thing in these families' lives. There's a lot of fear, there's a lot of conflicting priorities in the clinical setting. And I was working with these clinicians, with these very busy, very well, highly trained cardiologists who recognized how important physical activity was, but just didn't have the time or expertise to really, do some research around that. So, that was really where I experienced how amazing research can be when we work together. As an academic, some of my most impactful papers came from that work. But then what happened is I relocated to Kelowna because it was time for me to set up my own lab as a scientist, as an assistant professor. And I realized very quickly that things would be very different here in Kelowna working with Interior Health. And what I mean by that is I thought I could just continue what I had learned, but it turns out, every health authority is very different. The processes are different, the people are different, the organizational structures are different, the language is different, the culture is different. And I really had to start from scratch to really figure all this out. And it took years to get there. I'm happy to say today that all my research is partnered with clinicians, many of whom are in the interior. So I got there, but how did I get there? Really, there's no substitute for relationships. And there's a lot of hidden labor that goes into making that happen. And a lot of time is required to make that happen. And that's where it gets tricky for academics, because especially as early career academics, we don't really have that time. The pressures to build a well-funded research program quickly so we can get tenure are very, very real. And it's very conflicting to be able to say, yes to a lot of things that may or may not result in some partnership 5 years down the road. But I was fortunate to have a Michael Smith Scholar Award that is partnered with Interior Health, and that's really sort of like catalyzed a lot of things for me. So I was able to get different people around the table to have certain conversations to troubleshoot some of the challenges I was running into. What I will say, a bit of unsolicited advice going forward. So again, to the academics, I would say, you know, you have to say yes. You have to go to meetings you're invited to. You have to go to events you're invited to, because you may or may not meet somebody who turns out to be an ally or a friend. You have to say yes to supporting projects, clinical projects that you don't really have an interest in, but that might enable you down the road to ask for a favor in return. And the other thing that I've learned is I go by this mantra. I always look for the MGI. So this stands for most generous interpretation. I borrow this term from Dr. Becky, who's a clinical psychologist and parenting expert. And she urges parents to use this term when we deal with our very challenging children. So what's the most generous interpretation when we're confronted with a behavior that we don't really, you know, want to deal with? And so as an academic, if I go to the health authority or a clinician and I have an ask and I'm met with resistance, what's my most generous interpretation for that resistance? Did I do a good enough job to design my study in a way that will have the absolute least amount of impact on the clinical team? Did I do a good enough job to explaining that? Did I, you know, do I have a budget to compensate clinicians for their time? Like all these kinds of things. And I urge the health authority or the clinicians to do the same in return. You know, what are the researchers' motives for coming to me today to ask for support for a research study? Usually it's because, you know, we want to do research that's going to have a positive outcome for a clinical population in the long term, or the general population in the long term. Yeah, and then my last advice or request from all the administrators in the room, so that the administrators at the health system level, what resources can you make available to your clinical teams on the ground so that they may be more likely to say yes to supporting research? The number one issue I've always encountered is time and resources. People are understaffed. They just don't, I've yet to meet somebody who doesn't believe that health research is a good thing. But most of the time there aren't enough staff to provide the care. So then obviously the research will drop on the list of priority. And to the university administrators, I beg you to recognize all this labor as service. So it's literally in our job description as academics that we have to spend time on service. But find a way to recognize, and this especially for the departments that are not with the Faculty of Medicine, because I think we have it a bit easier in that regard, but find a way to recognize that some of this relationship building that has to happen to build meaningful collaborations with the health system or individual clinicians, recognize that as service, so that it's not sort of like free labor that we have to invest to build our own research programs. And I'll stop here. Thank you.
Lovely. Thank you very much indeed, Christine. And I'm certainly going to remember MGI. I think that's a really good piece of advice in this particular context. So we're going to go to our fourth panelist, Leah Lambert, who works at BC Cancer and also at UBC Nursing. So Leah, please, over to you.
Yeah, thanks so much. And thanks for having me today, and some really important points that Christine raised, and definitely some shared realities of what I've faced in my career as well. I'm coming to you from the unceded ancestral territory of the Musqueam, Tsleil-Waututh, and Squamish nations, and also just like to acknowledge the Métis and Inuit people who call this area home. I am a clinical nurse scientist and the Executive Director of Nursing and Allied Health Research and Knowledge Translation at BC Cancer, and that's a provincial department in BC's cancer system. And as Sterling said, I have a cross appointment at the UBC School of Nursing. And I wanted to just share a little bit about my story on how I got here, because I'm often asked, because this is a very unique role. It's the only one that exists within the Canadian cancer sector. And definitely, it speaks to some of the pieces that we're talking about today. So my story didn't start where I was here in this current role or in this space. Before nursing, like many people, I had different experiences, and I spent nearly a decade in business and finance. And I was focused during that time on compliance, numbers, systems, really skills that I never expected one day would help me kind of reimagine how we deliver cancer care. And it wasn't until I began my work in oncology after my younger brother was diagnosed with cancer at a fairly young age and had, a relatively poor outlook. Fortunately, things went very well, and he had an incredible team at BC Cancer, and that's where I say igniting my passion for oncology. But that's also when I saw a different kind of system failure, patients falling through the cracks, brilliant nurses being underutilized, as well as, communities facing enormous barriers, especially when we think about those who have less access to the social determinants of health than other people. And so it's there where my research began, not just in the clinic, but in those gaps and opportunities at a health system level and also a provincial and national level now. And so over time, my work, it's grown into a program of research, really centered around three core priorities for myself right now that are directly aligned with the 10-year Cancer Action Plan. And I think that's a critical part of what our responsibility is as researchers, especially those of us embedded or working very closely with health systems, is to ensure that our research programs and our priorities are aligned with organizational or health system goals and objectives. So mine, kind of falls within three pillars, one being improving equitable access to cancer care, second, innovating models of care, and then thirdly, developing nursing workforce policy and strategy. And what's exciting is that these aren't separate threads. They're actually really deeply connected. For example, recently I led a nursing workforce transformation grant funded by CHR that centered around the clinical nurse specialist role, which is one of two advanced practice nursing roles recognized in Canada. And this work really wasn't just about better defining those roles. It was about mobilizing provincial evidence, made in BC evidence, to directly shape provincial workforce policy that, originally was developed for BC Cancer and PHSA, but ended up having greater relevance for not only the province of BC, but now is being kind of taken up across the country. And so it's informing things like hiring, training, retention strategies across all our health authorities in BC. We worked very closely alongside every chief nursing officer in the province and the Ministry of Health to ensure that our policy recommendations didn't just sit on a shelf, that they were ready in terms of being able to be rapidly implemented into the health system. So developing really pragmatic practice-ready strategies such as standardized job descriptions, improved onboarding, and then now developing a province-wide toolkit that other health authorities are taking up in their contexts. And I think that's a good example of what research integrated care can look like. It's that tangible system level change that's driven by evidence and more specifically contextual evidence, because what works in Ontario might not work here in BC. And so I think it's an important part of understanding our own backyard and developing the kind of evidence that we need to inform organizational decision maker, health system transformation. And then more specifically, co-designing that with our health authority partners. And I think that's like very, very critical in this current context. There's increasing pressures, there's economic, downturn happening across the world. And so things like this CNS workforce work that I've been doing, it's now shaping federal dialogue with chief nursing officers from across the health ministries. and other provinces. And I think that's really exciting. And it's something that, you know, BC can be proud of in the kind of work that we're leading when we're supported, you know, from an academic, but also a health system perspective, to be able to not only steer the direction of what happens in our health system here in BC, but then share that knowledge across the country. Because the reality is when you look at things like workforce, we're all facing similar challenges. And of course, system change, it doesn't happen in a silo. For example, my work in cancer equity, we brought researchers into Vancouver's urban core to listen, but like really listen to the people living with cancer and who are also facing deep-rooted inequities. And so this project enabled us to build some new bridges between community health centers, for example, on the downtown east side, and BC Cancer, and working to help redefine what not only meaningful engagement with community advisors and partners looks like, but also how we can think about creating greater intersectoral collaborations, co-developing trauma-informed approaches, and what, you know, surfaced was an equity-focused research questions that are now guiding our own work. And I like to say that, you know, I'm interested in impact, in real-world impact, improvements, change, innovation, et cetera, and whether that's through research methodology or KT or QI or LMNOP, at the end of the day, it has to be in service of, you know, why we're all here, and that's serving and continuously improving the way that we provide care and support to the communities that we're responsible for caring for. And so, you know, one of the things that we were charged with in this session is thinking about what some of those big and shared priorities are. And for me, it's building sustainable research practice partnerships that don't just inform policy and health system work, but evolve with it and are responsive to the health system and organizational priorities and needs and population needs. And so that's about recognizing the expertise that exists across our systems, because there's tremendous expertise in our system in terms of either physicians or researchers or nurses or allied health providers, and then community connections as well. And then what does that connection look like to our universities and the kids, the young adults that we're, you know, training to step into these professions, which we also know is a huge challenge. And so how do we create the structures in order for that knowledge to move freely in that bi-directional way across kind of those historical divides of practice, operations, policy, and academia? And so in a future state, I'd really like to see more embedded research roles become the norm and not the exception to some of the roles that we hold here today, and position that so it sits squarely at that intersection of practice, policy, and research. And I think that's what we need in order to advance a true learning health system here in BC, and then continue to drive those evidence-informed, you know, organizational decision-making, practice improvements, system transformation. But what we also need is academic institutions to also rethink, you know, Christine touched upon redefining reward and impact so that the work of translating that research into better care is seen as central and not necessarily secondary. And so I think ultimately we have to create that space for those partnerships. And as Christine highlighted, that takes a lot of time and it's really, really difficult to do. But if you invest that time, my experience has been is that the kind of research you do is much more relevant to the contemporary health system in which we're working today, and making sure that those partnerships, you know, are in service of equity, they're in service of the people, and for fostering embedded applied research that's close to practice and health system operations. And that's the kind of work that I'm proud to be a part of here at BC Cancer. And fortunately, my organization has seen the value of that, has invested in that. And of course, you know, I've been, you know, hugely benefited from the support of organizations like Michael Smith, and I also hold a Scholar Award. But I think it's across those different sectors and organizations. This is our responsibility to create this environment and to ensure that the right pieces are in place to sustain it as well.
Indeed. I mean, the passion just oozes, and it's just wonderful that the importance of this conversation, particularly at this time, given the challenges that we're facing. So one of the things, so please put questions on Slido. We've got some questions coming in already. I will try and get to all of those. But I just want to, first of all, like reflect a little bit on, I think it's something that's been a theme throughout the comments is like there's a sense in which like we're trying to bridge. So it's sort of them and us. And like, how do we bridge between them and us? You can decide whether you're part of the them or whether you're part of the us. Or is it about the embedded model? Like, should we actually be trying to really like bring research and researchers to be within the system, and actually like sort of the voice then is louder because they're actually embedded within. So I think like just give I mean, who wants to give a reflection? I'm not going to get at everybody, but I'll pick on Kathy. Can I ask you to like just reflect from your experience in a leadership role? Is it them and us and bridging, or is it about embedded?
I think it's both. So I'm a real fan of embedded research, and I think there's opportunities for that to occur. But I think we could get too rigid on one methodology versus another. I think it's being open to what the opportunities are, and embedded research is excellent in terms of doing all the things that Leah talked about. There's also the more traditional kinds of clinical research and biomedical research that we need to have continue, like in all the pillars, so that it can inform the work that we do. I think what's really critical, though, is that there is a relationship between those who need to use that research and the researchers. And an example I'll give you is when we were doing some work on innovation in primary care in the North, we approached a group of researchers they weren't embedded, but they were a team that worked alongside us. And we had conversation about how the knowledge that they were capturing could be translated to us in real time. That's a challenge for researchers because it's also new knowledge that they need to be able to publish. But we found a way to do that so that we could learn as they were working alongside us in a qualitative research environment, and informing how we would go forward. And we did quite a few course corrections as a result of some of that knowledge that they were able to impart to us. So I just give that as an example. I think the secret is to find the thing that is going to enable knowledge to be taken up.
Great, thanks so much, Kathy. I think that's sort of like challenging researchers to provide some sort of guidance before they're feeling comfortable about like whether they're confident that there is a signal and not just noise. I think is like a really interesting challenge to address. I will encourage you. I'm going to be democratic about the Slido, so I'm going to take the most popular questions. But does anyone else on the panel want to just first of all respond to the embedded versus them and us question? And then we'll go. Kate, please.
Yeah, so I think, I mean, it depends, but I'm a huge advocate for that. If we could do a better job of embedding, I think that really is a bit of the secret sauce. One of the questions we were prepped with prior to doing this was like, what are the successful things that have happened in your sort of areas or from your perspective? And one of the things that we've piloted a few times now within Fraser is bringing academics to do their sabbaticals within the health authority. So they gain experience and like frontline, they're in the thick of it, but it's a more fiscally like achievable thing. You're not coming up with a budget for like a clinician scientist in the system. Although, please don't get me wrong, I would love to have clinician scientists in every single program and department. But you can come up more easily with the 20% top up that it might cost. And so then you're starting to get creative and making the system work for you. And we've had a few, we call it the Fraser Health Faculty Fellow, and we've had a few really amazing success stories with that. And those partnerships continue now. So like the sabbatical's done, but the partnership and the research is continuing, which is super cool. So embedded all the way.
Great, thank you so much. As you've been here in Kelowna, Okanagan seems like a rather attractive place to sabbatical. I would suggest. I'm sure the north has its charms, Fraser, Vancouver coastal, as well as interior. But have I forgotten anybody? No. The island. Sorry, of the island has its charms as well. Okay, let me go to the most popular question on Slido is, can we hear more about the MOUs, what they look like in terms of commitments and how to account for change in leadership and health system priorities? So I think the MOUs, Kathy, I think you made reference to MOUs. So
Yeah.
what might that look like? Just briefly.
Yeah, so I was involved with drafting 3 of the MOUs in the time I was with Northern Health, and there's a new one in progress right now with the different leadership team. And it varied according to where the relationship was at, where the partnership was at, and what we were working on together. So the very first one was very focused on the establishment of a health research institute at UNBC, and what the health system role was going to be with that, and how we were going to partner and build relationships and communicate around that piece of work. That evolved to the most recent one was focused on how we were going to establish something related to clinical research, clinical and biomedical research in the North, which there is a dearth of that for northern populations. So there was a focus on that. We often addressed funding and how we were going to partner in relation to funding of research, how we were going to communicate together and out publicly about what we worked on, and how we were going to govern the work that we were going to do together. So it was very much about building relationship, making space for partnerships, and doing actual concrete work on the next piece of opportunity and strategy that would create a culture in the North that was focused on research.
Thanks very much, Kathy. So I'm going to go to a question that's about how do we gain the trust of the public and communities, and the buy-in from public and communities that care is research and research can be care. Who wants to give us a go at that?
I'll take a stab, Sterling.
Let's go, Kate, and then I think Leah, if I'll come to you after that, if that's okay.
So coming a bit full circle to when you first introduced me, Sterling. So yes, the research directors were involved with a sort of a tagline, research is care, but it actually came from a patient partner. They were the ones that actually tagged it and recognized, like, and because of course this is in the time of COVID, that we needed to be doing better, and opportunities for research needed to be available to the public. And then of course we work really hard within the system and in academic institutions to support things like patient-oriented research, and making sure that the research that we are doing in the system is co-designed, not only with academics and decision makers, but with partners and community organizations and community members. So, and my brain just went dead. So I think that's the end of my thought. So Leah, take it from there.
Okay, thanks, Kate. Leah?
I have those multiple times a day. I'm just thinking about some of the real world examples that we have found to be effective. I don't know that you're going to gain necessarily a large public perception around that. And I'd say that it does exist to some degree. And I wonder how much science is, there's more public awareness around the critical role of science in relation to healthcare, in relation to climate change, which is also related to healthcare, just as a result of the geopolitical situation around the world. And so it's entering those public conversations a lot more than, I historically remember. And, even if we think about some of the examples that are happening in the US, and even around autism, let's say, for example, I think it's entering that public dialogue more, so people perhaps have a greater awareness. But I think on a more local scale, my experience is that engaging meaningfully with the communities that you are looking to serve and work with, because ultimately, those are end users, and that terminology is used a lot across the board. But what are their needs? What are their priorities? Because what you think is a priority, or what your organization thinks a priority, maybe isn't their priority. But also they have some good ideas around really pragmatic, fairly easy to implement things that, unless you have someone who is embedded in a kind of an investigative capacity and engaging with your ultimate end users and in the communities we serve, that work just doesn't happen. And so I'm just thinking about our work in the downtown east side and engaging not only with people who come for care in those neighborhoods, but also the service providers and the clinicians that work most closely, with folks at their clinics, and giving us some really pragmatic examples around, like, 2 years ago, I talked to a radiation oncologist, and it was a 2-minute conversation. The family doctor knew what was happening. The radiation oncologist knew what was happening. The patient felt supported, and things went much more smoothly than what they, have seen in other cases. That's pretty simple to implement, right? But if you have two systems that aren't necessarily working together on those issues or talking to each other at the right levels, and then you have people in respective organizations who can translate that back into suggested changes, whether it's at the individual clinician, the team, the program, the system level, those kind of things just don't happen. And I think sometimes we think about innovation as, big shiny machines and, genomics, but there's some applied health system research that we can be doing that can actually result in really impactful changes.
Thanks. Thanks very much, Leah. I just want to build on something that I heard that was intriguing, was like this tension between like seizing opportunities and being responsive versus understanding strategy for organizations and being aligned with strategy and like being very strategic. So like, do we like where do we go with that? Like how responsive do we need to be to grasp opportunities when they arise versus like building relationships, and being very strategic and being very aligned with strategy? Christine, do you want to speak?
Sure. So as an academic, I will answer that wearing that hat, because I actually really struggle with that, because as an academic, we're hired for very specific expertise and the very specific research skills we have and programs we build. So like, it's a real conflict often that, you're kind of supposed to align with someone else's strategic priority, when actually the job you're supposed to do is like, blossom in and really like grow into a world leader in a very, very niche thing that you trained in and became an expert in. So there's a bit of a clash there. And so from my opinion, whenever I hear, the whole like, oh, the strategic priority is this and we want to do this, I always feel like almost a little bit left behind, because now there's been an environment created that isn't really recognizing that I'm right here. I have like really good skills, which may not necessarily exactly align with that priority, but maybe there's some middle ground somewhere where we could actually achieve something today, as opposed to building into a strategic priority where, it's going to be 10 plus years before you have that academic in that position who is exactly trained to advance exactly that priority. So, that would be my perspective as an academic on that point.
Great, thanks. Thanks very much. I will go back to Slido in just a second, but I want to pose maybe Kathy, could I ask you to reflect on, I'm not going to ask you when are you coming back out of retirement again, but if you were working in the system today and recognizing the pressures that exist and the reviews that are happening and the imperative that's being given to resources being directed to frontline care, how do we like protect the researchers care as research message and the importance of research in an environment that we're currently facing?
So that's a million-dollar question. And if I had the answer to it, I think we could all go home. I do believe that in some of what we've talked about already, there are answers. So that notion of embedded research that is informing care and service provision, policy practice as we go, I think is part of, as someone said, the secret sauce. I think that having one of the things that was really important for us in maybe a slightly different context was making sure that the board for our organization had a really good understanding of the importance of research and what a difference it made, and making sure those stories got told to those people who are governing the healthcare system. So I think we need to think about all of those places where we need to describe that. And, I take Christine's point around the sort of unrecognized work that this is, the legwork that it takes. So those of us who are leaders in the system need to take this to heart and spend that time talking with the decision makers, whether those are in the ministry, at the board level, in our communities, about research whenever we can thread that into the conversation about what we're trying to do in the healthcare system in terms of quality, in terms of improving the service delivery system for people on the ground, for our service providers. The other piece that I have been struck with over the years is how passionate many health service providers, physicians, nurses, allied health professionals are about research. And giving them opportunities to actually engage in research is a message in itself. And I think we've been able to recruit people to the north because they would be able to be engaged in research endeavors. And that needs to be communicated out publicly so that people understand how important this is to service providers, how important it is to the people we serve.
Great, thanks. Thanks very much, Kathy. And I mean, I've seen the success of the practice-based research challenges that exist in many health authorities that speak to the enthusiasm that people working on frontline. On the front line, the clinicians see in research. So, and actually linking it to the health human resource challenge that we have at this point as well, I think is like research as a mechanism to obviously in part address some of those challenges. I think it's really important. Okay, can I ask? So there's a lot of interest in the embedded research model. So are there, one of the questions that we've got on Slido relates to how do we advocate for funding for embedded research? And what are the strategies by which we can actually persuade folks to support? I mean, Kate, your suggestion of, is a sort of like almost a way around us needing to get much additional funding for those roles, but how do we advocate effectively for support and funding for embedded research within the system? Leah, do you want to start us off on that?
Yes, so I get asked this question all the time from all around the world, actually. How did I get this role? What did my journey look like? How is it funded? Who do I report to? All of those pieces, which are critically important. I think, in the case here at BC Cancer, and similar to what, Kathy just discussed, is it needs to come at a leadership and a structural level. And so I think she's right in terms of the board being a critical piece and understanding the value and making that explicit within their organizational mandate, that research is an integral part of the operations and the care that is delivered in an organization, and then building the necessary structures around that. And that is literally how my department came to be in this role. And it takes money. It takes, money for salaries, for associated infrastructure. But I would say that the payoff is massive. And the kinds of work that folks are able to do when they are inside the system and are not knocking from the outside to get in, they're embedded in the culture. They're embedded in the operations. They are aligned and have access to decision-making tables, in my case, for example. And so that I see that paying itself off in tenfold. But that needs to happen, I'd say, at that higher level in our province. And I know Michael Smith plays a key role in that in terms of driving that. But I think, we are at a critical juncture right now with the review of health authorities. And, it is a question, I think, on many people's minds is, what is this going to look like? And is research going to continue to be seen as essential part of our health service delivery models? And then how do we not only sustain that, but then grow that in the future? Because I agree, we need all, I partner very closely with, tenure track faculty, but also operational leaders. And so I think it's multiple people's responsibility to continue to foster that.
Great. Thank you very much, Leah. Does anyone else want to pick up on the challenge of bringing resources to an embedded researcher model? Thank you, Kathy. Oh, did I see your hand up? No, I didn't. Okay.
No, but I will just make one comment. I think that some of the creative ideas, like that sabbatical idea that Kate gave, we did that once on an Indigenous piece in Northern Health, and it did result in a VP of Indigenous Health. So I think there's something there. And also master's students, PhD students, and how you can create opportunities for people to do sort of embedded research. And the more we do it, the more it will perpetuate itself.
Yeah, thank you very much.
Just really quickly to follow on from that, medical students too. So the medical students for me have been one of those vehicles that has allowed me to build relationships with local clinicians where, somebody wanted a project done, but didn't really have time to supervise a student, didn't know how to do ethics, all those kinds of things. But that's where I then came in. And so that's perhaps easier for me because I'm attached to the medical school and I understand their curriculum and I have access to the medical students. But again, I think the payoff is great because these are going to be the future doctors who are going to come with research skills and an appreciation for how important the research is. And so, yeah, I just wanted to put a plug in for the medical students.
Thank you very much indeed. So we're drawing to a close. We've got 2 minutes left. So I'm not going to go to any more questions on Slido, but I will make a comment there's a comment. I think I know who this is from. Thank you, Lisa. Patient partners also need recognition for our service, in brackets, unpaid, and spend tons of time building relationships. And I do think that's important to recognize. So thank you for that comment. And if it wasn't Lisa, thank you for whoever it was who gave that comment. I just want to reflect, thank you very much indeed, panel and people who've given questions. I think that's been an enriching conversation from my perspective. So just to reflect on what I've heard and what I'm taking, some of the things that I'm taking away, seizing opportunities, as well as being strategic. and actually recognizing that it's okay to see an opportunity and to grasp that opportunity, even if it's not necessarily, or at least you can't see at that point that it's aligned to strategy, but obviously being aligned to strategy as well. So that tension between seizing opportunities and being strategic is, I think, something that we need to reflect on. Partnership, like, came through time being committed to building relationships, establishing partnerships, both formal as well as informal partnerships, critically important. I love the idea of recognizing or reflecting on the most generous interpretation on response when moving forward. So MGI, I'm definitely taking away. I also like the fact that it's important to have favors owing, and actually, like, that is a strategy to build relationships. I probably need to work harder on that one, to be honest. But yes, that's a good one, and thank you for that, Christine. And I think the co-design, like, message that we had as well, the importance of that co-design and reflecting on who are the partners who are part of that co-design. So at that point, I think we draw to a close, and I want to say a huge thank you to Kathy, to Kate, to Leah, and to Christine, and to everyone who's contributed to the conversation. Thank you very much indeed.
And Sterling, we want to thank you. Thank you as well. Thank you. That was a wonderful panel. I want to add one thing where one mentor along my way, Ross Halprin from BC Cancer, said, research is the engine of hope for both patients and the staff and researchers. So that really resonated with me. And I think it is, again, another reason why care is research and research is care. So thank you all so much. This session is coming to a close. You have about 5 minutes until the closing plenary will begin. So thank you again, and top up your coffee.